Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. Today, I'm going to share with you this interesting case of pilocytic-astrocytoma of the posterior fossa in an adult patient. So this is a 20-year-old female patient who presented with unsteady gait and was found to have posterior fossa mass. And the mass was actually cystic with a mural nodule on radiology. Now, during intraoperative consultation or frozen section, the squash prep, and I'm going to show you in one of the videos the preparation of a squash prep and touch prep as well. It shows a cellular tumor with cells, the nuclei that are somehow oval in shape and with abundant acidophilic cytoplasm. Now, other areas show this collection of cells, of tumor cells, fascicular nuclei, no prominent nucleoli. If you pay attention, there isn't much really in the way of processes in the background. There is no mitosis nor necrosis. Now, other areas show this Rosenthal fiber, and yes, on smear preparations, Rosenthal fibers can be identified if you pay enough attention and look for it specifically. And then we have this beautiful, this one and this one, piloid cells with elongated hairy processes, and piloid means hair. So these are the typical cells that we see with pilocytic-astrocytoma. And these cells in the background are also part of the tumor. Some granular acidophilic granules here, acidophilic granules identified here, and more Rosenthal fiber, more of those cells with some pleomorphism, if we pay attention, tendency at aggregation, and then the eosinophilic granular bodies that are identified as well in pilocytic astrocytoma. And if you pay enough attention, it can be identified in smears. And again, the cells, most of the cells show pleomorphism, cells that are large, besides cells that are smaller, really enlarge the nuclei, but no apoptosis, no mitosis, and no necrosis. However, in some areas there was evidence of what appeared to be microvascular proliferation or vascular proliferation. Again, another Rosenthal fiber here, and as you can see, a lot of pleomorphism. Now, the section, the frozen section itself showed, it wasn't as cellular, I have to say, and it showed Rosenthal fibers and then the scattered cells, some with pleomorphic features, but again, there was no evidence of apoptosis, mitosis, or necrosis. Now, for the permanent section, as you can see, the tumor was actually biphasic, and it showed areas resembling this area with microcyst formation here, here, and here, and then cells with vesicular nuclei, not much in the way of piloid cytoplasm. There isn't much piloid cytoplasm. They are very monotonous, and then there was no evidence of mitosis or necrosis or apoptosis. Again, another focus of the microcystic areas with the myxoid degeneration in the background, some hyalinization of the vessels. And remember, in the central nervous system in particular, hyalinized vessels would equal or mean long-standing process. So we tend usually to see hyalinized vessels with low-grade tumors, meningiomas, schwannomas, pilocytic astrocytoma. So this is a good clue that we're dealing with a long-standing process. And then the cells somehow resembling, in a way, if I may say, oligodendroglial cells, because they have round nuclei and they are sitting within clear spaces reminiscent of a fried egg appearance. And if we go back to the frozen section, to the smears in particular, this area actually resembles exactly this group of tumor cells that I showed you before. So this group of tumor cells that we've seen on the smear corresponds to the area with the microcystic degeneration. Now, into another area in the in the section, in the permanent section, which is the more cellular solid area, I have to say, in which Rosenthal fibers are seen. And remember, we do not usually see Rosenthal fibers in the microcystic areas. Rather, we see Rosenthal fibers in the solid areas. And again, we have the cells with the long processes apparent or obvious more in the solid areas. So this area actually corresponds to this area in the smear that I shared with you at the beginning of the video. These are the Rosenthal fibers, and then these are the piloid cells. And this area shows more kind of something in between, some myxoidish degeneration in the background, but definitely pleomorphic nuclei can be identified. And then we have the eosinophilic granular bodies. And again, this area corresponds to this area in the smear in which we identified the eosinophilic granular bodies. And we identified more pleomorphism than the previous two areas. Now, the GFAP, of course, was positive in the tumor cells. And as I alluded to before in earlier videos, the GFAP is important to identify microvascular proliferation. But remember, microvascular proliferation can be seen in pilocytic-astrocytoma. It stays, it remains grade 1. It does not change the grade. So microvascular alone in otherwise well-circumscribed tumor, something like pilocytic-astrocytoma, does not really alter the grade. This is not a grade 4. Although if I see the same microvascular proliferation in an infiltrative glioma, and this is the clue, in an infiltrative glioma, this would really be very suggestive or would support the diagnosis of high-grade glioma. So GFAP immunostain highlighted the microvascular proliferation, which is okay in circumscribed gliomas like pilocytic-astrocytoma. Important also to notice that these structures, which only have a rim of GFAP positivity in the background here and here, are the Rosenthal fibers. So Rosenthal fibers are typically GFAP negative, and this is like the negative image of the Rosenthal fiber. So this microvascular proliferation really corresponds to the vessels that we've seen on the smear preparation. So remember, microvascular proliferation can be seen in well-circumscribed gliomas, including pilocytic-astrocytoma, and this does not upgrade the tumor. Now, important in order really sometimes to sort the differential diagnosis, whether this is infiltrative or circumscribed glioma, we have to do neurofilament protein. And the neurofilament protein tends to show this is the normal brain, this is the edge of the tumor, but as we move in towards the center of the tumor, the amount of the neurofilament proteins, which positivity and neurofilament proteins are nothing but the axons of the neurons within the central nervous system, becomes less and less. So on high power magnification, this is the area in the middle. This is towards the normal brain, and this is towards the center of the tumor. And as you can see, there is a gradient. The neurofilament protein positivity becomes less and less positive, and this is in the middle of the tumor, almost no positivity. So if we put them all together, neurofilament protein, this is the edge of the tumor, this is the normal, this is the where the tumor really starts, but you can easily actually with a pen draw a line separating the normal from the tumor, which would not be the case with infiltrative gliomas. And then we have this area in between, and then finally we have the area where the tumor does not show evidence of infiltration, so it doesn't show evidence of a neurofilament protein positivity. And finally, the Ki-67, despite some of pleomorphism, but as I showed you, there was no evidence of mitotic activity anywhere. And then only a couple of Ki-67 positive nuclei, meaning that most of the tumor is non-proliferatively active. So it's not mitotically active. So the final diagnosis, when put together this case in correlation with the radiology, despite of the age of the patient. This would be consistent with pilocytic-astrocytoma CNS WHO grade 1. I hope you find this tip useful in your daily practice. Thank you.